Thomas Baldrick here at ASH 2014 in San Francisco. Delighted to have with us Dr. Claire Harrison from Guy's in St. Thomas in London. Thanks for stopping by again.
No worries, great pleasure.
So let's just chat. Where are we in the MPN space today?
So the MPN space, we're a decade on from the first description of the JAK2 mutation, and at a point where just this week, ruxolitinib, JAK1/2 inhibitor, Jakavi, has been approved by the FDA for the management of PV patients based on the phase 3 study, the RESPONSE trial. I see at this ASH a lot of information about incorporating molecular data, the calreticulin mutation, epigenetic mutations into prognostics, particularly in myelofibrosis. I see data with regard to efficacy of JAK inhibitors, but also other therapies like interferon in terms of the management of PV, but also some practical issues and hands-on practical management being really incorporated into clinical practice in a very standard way in terms of, basic day-to-day management of patients, which is really important, particularly as we're using newer drugs all the time. So we really all need to be very much abreast of what sort of standard management is now in 2014, looking into 2015.
Where do you think you are in handling the big challenges of the day?
So I think in the past, looking back, our big challenges actually were in achieving an accurate diagnosis. And I think the advent of molecular diagnostics really helps us a lot with that. It also helps us in terms of prognostics. Some of the challenges that we face across the world are actually with reimbursement of modern therapies. So many of us will be thinking, well, great that the FDA has approved ruxolitinib, but well, in England, we have to face NICE approving this drug, gather more data, etc. The practical challenges are really also in how we handle these drugs, which patients we consider for them, and knowing longer term as well as short term toxicity. So things like, how do we know when our patient is continuing to respond with ruxolitinib, if, for example, for a myelofibrosis patient? And which patient might we consider for some of the many clinical trials that are going forward? For example, the combination studies. We see at least 5 different combination strategies presented at ASH. An example being the combination of lenalidomide and ruxolitinib, danazol and ruxolitinib, and then the phase 1 studies where we're combining different molecular targets, smoothened, HDAC, BKM120, which is a PI3 kinase inhibitor. So we're learning about which patients we should be using that on, and then also coming along now, a third JAK inhibitor. So I think one of our last conversations was about fedratinib and the unfortunate occurrence of Wernicke's encephalopathy for those patients, leading to a clinical halt for this drug. So we're a bit further on in understanding why did fedratinib cause Wernicke's encephalopathy, structurally very similar to thiamine, inhibits thiamine uptake, and also crosses into the CNS through the blood-brain barrier. And coming along now, we see pacritinib and momelotinib, both of which are in phase 3 trials. We expect and look forward to the phase 3 data from pacritinib, the PERSIST-1 study, led by Ruben and myself, probably in the first quarter of next year, delivering something meaningful for patients who really are struggling with myelosuppressive toxicity of ruxolitinib, and the group of patients for whom they start to lose their response to ruxolitinib over time. We know ruxolitinib is a great drug, but there are some patients who are either not eligible or who are losing response. So still a really exciting time, a time when we're translating research into practice and consolidating what we know.
So about the recent approval of ruxolitinib in the PV space, pros, cons, challenges, key issues?
So specifically concerning ruxolitinib with PV, I think our challenges are how to manage the drug for PV patients and which patients we should be selecting. So the approval, as I understand it, is for patients who are having ongoing symptoms or not responding to hydroxyurea in the way in which we expect. We see very consistent dosing with regard to the drug. Interestingly, the efficacious dose seems to be a bit lower in PV, so many patients started around 10 mg BID. I think some issues remain with the basic management of PV though, so we mustn't forget to know our patient's vascular risk. Even if they're on ruxolitinib, we still have to know that. We still have to keep their hematocrit less than 0.45. We still have to use aspirin for those patients, and we have to be mindful of what our therapeutic target is, as well as side effects of ruxolitinib. So thinking about infectious complications, mindful of herpes virus reactivations, etc. So we can look to the new, enjoy the new, know how to use it, but still remember the really old-fashioned important facts when managing our PV patients.
Very good. Thanks for stopping by. Always a pleasure to see you.
No worries. Thanks very much.
Okay.